Hello, everyone. Welcome. We're just going to give people a couple of minutes to come into the room, and then we'll get started. Thanks. Great. So good morning, good afternoon, good evening, everyone. Thank you so much for taking time during this very busy time of year to join our webinar called Funding Can't Wait, New Global Fund Opportunities for Viral Hepatitis. So just to start out, just to make sure that we can all understand each other, just to let you know that we do have simultaneous translation available in English and in French. Next slide, please. So hopefully you're used to this by now, but you'll see on the bottom of the Zoom screen a little globe that says interpretation, and then just please choose the language you wish to use throughout the webinar. If you have any issues with the translation or it's not clear, please do put a note into the chat, and we'll do our best to fix it. Great. So we have a really great selection of panelists today here to talk about the new opportunities in the current Global Fund Global Fund Information Note that can support hepatitis services. So in this webinar, we're really going to explore the opportunities for countries to include hepatitis programs in their proposals, and also going to go into the mechanisms to do so. We'll also talk about some information that's available that can help people when they're making the case for hepatitis to be included in those notes. And then we're really going to take a deep dive into one country to see how countries have used resources from the Global Fund for hepatitis in the past. But just before we get started, I'd just like to invite the World Hepatitis Alliance President, Danjuma Adda, to say a few words of welcome and a few words about the webinar today. So Danjuma, over to you.
Thank you, Carrie, and thanks to all the partners that are involved in this call. And thank you all. Good morning, good afternoon, good evening. Thank you all for joining this webinar. It is an honor for us at the World Hepatitis Alliance to partner with CHAI and to partner with Global Fund to make this happen. Over the years, we have advocated for resources that will finance hepatitis elimination. And while we've had challenges in getting investments, we've had challenges in getting funding, the Global Fund provides us as a community an opportunity to advance or to drive the elimination of viral hepatitis. So in the context of no funding, now we have this opportunity to share the resources from the HIV. And this is an opportunity I call on all the civil society organizations, members of World Hepatitis Alliance, and all other partner organizations to not to take for granted. So we should take every advantage of this and ensure that we're able to draw the support from Global Fund to drive hepatitis elimination and, of course, to improve the health of our populations that we serve, either people co-infected with hepatitis or key populations that this funding will address. So I would like to sincerely thank, it is indeed great to have Global Fund listen to us, listen to all the years of advocacy from all global partners, including World Hepatitis Alliance, to get this happen. And we're glad to see that this is happening. So it's up to you, civil society, it's up to you, members of WHO, it's up to you, all global partners, to take advantage of this opportunity and to ensure that you draw funding to drive hepatitis elimination in the context of HIV funding in your country's request that should go out to Global Fund from next year. So thank you to all the panel members for being part of this. Oriel, Xavier from Global Fund, and all and every other person that is on the call. Thank you, Chai. Thank you, Global Fund. Thank you, all of you participants that have joined us for this. And I wish you all beautiful webinar. And let us please learn. Let us take away key lessons. Let us take away the key asks. If there are questions you have, please drop it in the ask question. We have all the experts here to listen to you and to take note on all that you have to say. So on behalf of the community, hepatitis community, I would like to say thank you to all the partners on this call. And I wish you all beautiful meetings and deliberations. Over from me. Thank you.
Thank you so much, Danjuma. So now we'll just have a quick round of introductions of our panelists. We'll allow them to introduce themselves. So Oriel, would you like to start, please?
Yes, absolutely. Hello, everyone. My name is Oriel Fernandez. I work for the Clinton Health Access Initiative, also known as CHAI. I lead our viral hepatitis program, and though I'm originally from Goa in India, I'm based here in Kigali, Rwanda, and just thanks so much to the World Hepatitis Alliance team for inviting me to join and present at this webinar.
Thank you so much. Javier.
Hi, everyone. My name is Javier Urcade Veloc. I'm based in Buenos Aires, Argentina. I am a member of the Global Fund Board, representing communities living and affected by the 3 diseases, and also working with Kari and others on universal health coverage. I'm happy to be here. Thank you for the invitation.
Excellent. Sopong, please.
Hi, my name is Sopong Pan. I am Senior Associate at CHAI Cambodia Hepatitis Program. My role here is to support the Cambodian government on HIV/HCV convention program, also the national program for viral hepatitis among general populations. I also work with the National Center on HBV PMTCT as well. Thank you, World Hepatitis Alliance, for inviting me and also Oriel to the webinar.
Excellent, welcome. And Sam.
Hi everyone, my name's Sam Shirley Bevan. I'm a researcher at Harm Reduction International, normally based between the UK and Bogota in Colombia. I work on monitoring global trends in harm reduction implementation and conducting research to support improvements in harm reduction provision.
Excellent. And the other, panelists are really all of you out there, because we've put aside a nice bit of time for us to discuss, for us to clarify any questions, and for just to hear from all of you about how you feel about these opportunities and how to make the most of them. So let's get straight into it. So I'm going to hand over to Oriel for the first presentation, who will give an overview of the situation with the Global Fund and some about around the process and the procurement. So Oriel, over to you.
Great, thanks so much. And I'll just wait for my slides to be pulled up. Great, Stuart, could you just move into the agenda slide for me, the next slide? Great, so hi everyone again. As Carrie mentioned, I'll be speaking today about the opportunities countries have to apply for funding for viral hepatitis services within their Global Fund grants for the next allocation period from 2023 to 2025. In my presentation today, I'll cover specifics around the hepatitis relations that the Global Fund will support in this funding period, both within their HIV allocations and applications and within RSSH investments, and I'll explain that a little later. I'll also talk a little bit about why this is a really critical and important opportunity for hepatitis and just the need to understand the country context and really for all of us to be targeted and strategic in how we prioritize areas for support. And then finally, I'll talk about resources available to help all of us in country, through this advocacy process. So can I have the next slide, please? Great. So this slide just shows you, the evolution of the Global Fund policy over the last few years. So over the last few years, CHAI, the World Hepatitis Alliance, and partners have engaged with the Global Fund to articulate the importance of integrating viral hepatitis prevention, diagnosis, and treatment services into ART, harm reduction, and ANC services to really improve the outcomes of people living with HIV and key populations, and then strengthen health systems overall. The great news is that this advocacy has led to the Global Fund evolving its policy over time. So, the slide shows a snapshot of the evolution of these policies. So starting in 2015, the Global Fund first introduced a conditional policy for financing for HCV drug and diagnostic commodities, specifically amongst people living with HIV. In 2020, the Global Fund then published a brief encouraging countries to make funding requests for all WHO recommended harm reduction interventions, including hepatitis services for people who inject drugs. In 2021, the Global Fund published a strategy narrative for 2023 and 2028, really urging countries to start to integrate viral hepatitis prevention, diagnosis, and treatment into multiple service settings. So these include ART clinics, ANC, sexual and reproductive health services, and harm reduction settings. And this year, the Global Fund has released more detailed guidance to enable countries to request resources to support viral hepatitis programming within HIV service settings, harm reduction settings, and antenatal care settings as part of a triple elimination approach. So these policies have really been detailed out across several documents. And on the slide, you'll see a box with the name of the documents. And when you receive the slides, you'll be able to click on them with links where you can find them on the Global Fund website. Can I have the next slide, please? So just to lay out a little bit more specifically what the Global Fund will cover in terms of hepatitis interventions in the next allocation period. Within HIV applications, countries can make requests to support viral hepatitis programming for people living with HIV and all key populations. This includes screening, testing, and treatment for hepatitis B and C, vaccination for hepatitis B within HIV prevention and treatment services, and sexual and reproductive health services and harm reduction services. Specifically for people who inject drugs and people in prisons and other closed settings, hepatitis B and hepatitis C services can be delivered as part of harm reduction services, and this is regardless of HIV status. For pregnant women and breastfeeding women, HIV, syphilis, and hepatitis B testing during ANC visits and hepatitis B confirmatory testing and prophylaxis treatment will be covered for pregnant women. And this will be in the context of countries really driving towards the triple elimination agenda. We should note here that hepatitis B birth dose vaccination for newborns will not be covered by the Global Fund. The commodity procurement will not be covered by the Global Fund, but a case for resources to support programmatic delivery can be made. So for countries looking to make these investments, we'll need to find other sources of funding for hepatitis B birth dose, and hopefully we'll have Gavi picking up the investments for hepatitis B birth dose soon. And then lastly, specifically in the case of harm reduction, we should say that the Global Fund has made it very clear that harm reduction is now an HIV program essential. So what this means is that all countries must describe the status of their harm reduction programs for people who inject drugs in their funding requests, and those countries classified as high impact must describe their plan for full implementation. The types of priority harm reduction and interventions that the Global Fund will cover are needle and syringe programming, opioid substitution therapy, and naloxone for overdose. The Global Fund will also fund hepatitis B and C treatment for people who inject drugs, regardless of HIV status, specifically if strong epidemiological cases and are made for those countries, and it's included as part of comprehensive HIV programming. And maybe the last point to make here is that the Global Fund has emphasized that specific human rights program areas must be addressed in their funding requests, and applications must really underscore the importance of the key role for people who inject drugs have in planning, delivery, and evaluation of services and policy change. So this slide just really lays out the specifics of what the Global Fund will cover for hepatitis in the next funding round. Can I have the next slide, please? Right. So in addition to requesting hepatitis funding support within the HIV applications, countries will also have the opportunity to request programmatic and health system strengthening funding as part of their resilient and sustainable systems for health grants. These are also known as RSSH investments. These investments recognize the importance of really improving overall health systems by boosting the quality of care, data tracking, accountability, governance, community engagement, and service delivery. So just by default, they are not meant to be disease-specific investments, but really meant to be investments that are integrated and support overall health system strengthening. The Global Fund has predefined potential modules, interventions, and activities countries can explore for cross-cutting and health system strengthening. So in the diagram on the left, you'll see the various RSSH modules the Global Fund supports. And these include aspects like community system strengthening, human resources for health, lab systems, and other areas. As part of this investment, there are many potential areas where hepatitis could be considered for investment within the RSSH grants. So if you look at the right-hand side of the slide, you'll see just one example snapshot of what this could look like. So if we took, for example, human resources for health as a module for RSSH, countries could include activities like training of healthcare workers and other staff to support rollout of hepatitis and other services that are integrated within HIV, SRH, harm reduction, and ANC settings. So that's just one concrete example of how, in addition to the HIV applications, we might use RSSH investments to continue to strengthen the system for hepatitis service delivery. Can I have the next slide, please? Right. So, I think the overall key takeaway here is, first of all, it's really exciting that the Global Fund has expanded and really clarified the policies for hepatitis programming. And this next funding round becomes a really critical opportunity for funding for hepatitis services. Although this funding can't be used generally for comprehensive national hepatitis program scale up, we see this really as an opportunity to do one of two things in countries: to either complement existing hepatitis services or enable the introduction of hepatitis services for the first time in a country that just really requires the catalytic support to start hepatitis programming. But really, it will take a lot of thoughtful planning, advocacy, and stakeholder coordination for us to be successful here together. Firstly, countries will need strategic, targeted, and prioritized requests. Not all countries can and should request all areas of the hepatitis services in scope. The requests really must be tailored to the country context. So, for example, if a country has a strong dual HIV and syphilis elimination program in place, they might use this next funding round as an opportunity to advocate to include HPV as part of a triple elimination program. Or another example is if a country has an HIV epidemic that's really driven by injecting drug use, then there is really an opportunity to build in hepatitis services as part of a comprehensive harm reduction program. The bottom line here is countries will really need to formulate a strong investment case informed by the epidemiology of the disease in country, programmatic needs, priorities, and articulate how these investments can help improve outcomes for people living with HIV and support the program to catalyze programming for future scale up of hepatitis services. I think secondly, successful outcomes will really rely on stakeholder engagement and coordination, and this is really critical. I think we have many stakeholders in country, and each stakeholder is advocating for different areas of hepatitis. So, what we really need to do is ensure key stakeholders, including the Ministry of Health, community advocates, and partners are aware of this expanded policy and this opportunity. And then the second thing is that these key stakeholders in country need to carefully evaluate what hepatitis-related Global Fund requests to make for this next round, and then move forward in the advocacy process to different stakeholders. And the chart on the right provides sort of a high-level snapshot of what that advocacy process could look like. Could I have the next slide? And this is my last slide. So, I think finally, we recognize that the Global Fund application process is very complex and it involves many stakeholders to evaluate and determine country funding priorities. And we also know that there's several Global Fund documents available on the website for all of us to navigate. So TRI, together with partners like the World Hepatitis Alliance, the WHO, and other partners, has developed a resource toolkit on the Global Fund 2023 to 2025 funding opportunity for hepatitis. And the funding toolkit really targets to equip all of us at a global level and in-country hepatitis stakeholders primarily with the intel and the tools we require to understand the Global Fund policies and support advocacy efforts for hepatitis services for this next round. The toolkit will be published this week at the end of this week and will be available on TRI's website and also be disseminated through partner and hepatitis networks. The right-hand side of the slide shows you some snapshots of what the toolkit looks like, but overall it will include a detailed summary of the Global Fund hepatitis-related policies that I covered very quickly earlier on in my presentation. They also include country case studies highlighting countries who have been successful in this process and how they did it. And my colleague Sokfung from Cambodia will speak to Cambodia's experience a little bit later. The toolkit also includes tools that include ready language for the rationale for making hepatitis-related investments, cost effectiveness rationale, a summary of the pricing and market access for hepatitis B and C commodities, and a generic advocacy work plan and activities checklist that everyone can take and tailor to their own country context setting. On this note, I just wanted to point out that the Global Fund has implemented a pooled procurement mechanism to support pooled procurement and enable countries to access drugs and diagnostics at more competitive pricing. Hepatitis B and hepatitis C treatment commodities are included in the list of eligible products for procurement under this mechanism. So as much as possible, we really need to encourage all of our governments to take advantage of this procurement mechanism to really access high quality products for more competitive pricing. So I'll just end here, and I'm really happy to answer any questions about this process over the chat. I hope this presentation has been valuable, specifically for those of you who are based in countries who are gearing up towards supporting and advocating for this next Global Fund application process and will be leading the efforts in countries. Thank you so much, and back over to you, Carrie.
Thank you so much, Oriel. That was super clear. The toolkit, so much work went into that. So I just want to say, thank you for all your efforts in coordinating that as well. Just before we go to Javier, maybe I'll just point out that we've kind of done a very brief overview to complement the toolkit. Maybe, Ben, if you could just bring it up. That's going to be available from the World Hepatitis website. And it's just really a community briefing to kind of, if you're kind of new to the process, you just kind of want an introduction to things. We've done this kind of short summary. We'll put the link in the chat. Yeah, please, use and disseminate that as well as the main toolkit. Thanks very much. So now we're going to go to Javier, who is on the Global Fund board. Here the perspectives from the board on the new hepatitis opportunities, and also about the role of civil society in the whole process. So Javier, over to you.
Thank you, Carrie, and thank you, Oriel, and also thank you for CHI and also the World Hepatitis Summit to be very meaningful partners of the Global Fund and pushing the agenda not only on hepatitis in the case of CHI, on many other critical issues, and helping the Global Fund on delivering more efficiently on our mandates and our programs. And a perfect example of that is what Oriel presented, which might make my presentation shorter. But I mean, it's important to re-emphasize what Oriel says in terms of what the Global Fund in related to hepatitis, and we are happy that now we have a more clear policy. As Oriel says, the Global Fund has been investing on hepatitis interventions for almost 10 years now, but there wasn't a policy in place. And there was the ability of the, let's say, funding requests, co-writers, the CCMs, and the networks and community activists to make sure that they squeeze hepatitis interventions, especially hepatitis B, for example, vaccination for people living with HIV, or hepatitis treatment for people living with HIV, or key populations, triple elimination. So all these creativity that the Global Fund Partnership have to bring things that might not yet have a policy. It's always it's in the future build a policy. You know, I mean, the Global Fund, it's a funding mechanism. Sorry for stating the obvious. That it's an operational organization. It's not an academic organization. Some of the technical expertise in the Global Fund staff or Global Fund Secretariat is to support that the implementation of some technical interventions during the grant cycle or during the grant of the Global Fund. But we rely a lot on the technical partners. When we say technical partners, people think about UNH, rollback malaria, stop TB, but not. We rely in the big diverse spectrum of partners, including CHI and the World Hepatitis Alliance and Input, Harm Reductions International, that through the natural delegation of constituency in the board or directly help us to move forward some policies. And hepatitis it's a good example. Of course, we do not have all what we need, or we will not have all what we need probably on hepatitis and other issues. And it's not necessarily linked to the outcome of the recent replenishment. In some way, it have to be with a funding gap that we envisage, but it's also part of the architecture of the Global Fund. Probably in this call, there's still some new people to the Global Fund. And one concept that I will come many times back to that is a country ownership. Basically, the country coordinating mechanism with all the stakeholders, ideally with key populations and civil society, come together in a country dialogue and prepare a proposal. So as soon as the Global Fund get less resources at the Secretariat to provide technical support, we can, as a Global Fund partnership, we cannot build demand, but we navigate, especially the civil society constituencies, will navigate very smart the way to support demand creation. We're talking in this meeting around viral hepatitis and, for example, hepatitis B and C, screening, diagnostic, vaccination, treatment, etc. But could be prophylaxis pre-exposition to HIV for a long period of time. And I think that as someone who actively follow toolkits and documents and campaigns, include, for example, the Clinton Foundation one, the reality is that the new strategy and the appetite of the board, both from the implementers group and from the donors group, is to continue to be aligned with the core mandate. We have a new strategy that I will mention in a minute, but basically, whatever we do needs to have an outcome related to HIV, TB, and malaria. And it's important when we talk about resilient system for health. I mean, nothing, it's not groundbreaking. The Global Fund has been working on health system strengthening for a while, including community health, community system strengthening for many years now. So it's RSSH is not something brand new. Probably it's more like a better understanding, better within the Global Fund partnership, especially with some donors who have a very high in their agenda RSSH. Of course, we do have that, but communities and civil society constituencies in the board and in the committees push for the side of our SSH that have to do with CSS, community system strengthening, and making understanding to continuously advocating like broken records that resilient system for health is not only hospital, doctors, and tracks to reach hard to reach communities affected by malaria. It's also providing resources and commodities and protection to community health workers. So this is for us, but community health workers, CBOs, NGOs who works at the grassroots level are part from the health systems. I don't need to convince you about that, but sometimes we need to remind some board members about that. And it's not only the donors, it's also some recipient or implementers constituency. So it's also important to understand attention after the last 20 years. I don't want to sound negative. I want to probably give you a glance of what happened at the global level when we discuss. There is always a tension between the technical piece and the political piece of any interventions, and that may create some challenges with the current approach to hepatitis and in the future. I give you a totally different example, which is not related to hepatitis. Let's talk about, but it will be related to hepatitis. Let's talk about transition, sustainability and transitioning, Global Fund exiting from middle-income countries with concentrate HIV, TB, or malaria diseases. And I mean, technically speaking, we have been fighting for since 2009. We provide evidence, we provide a lot of information where most of the people living with HIV lives, which are middle-income countries. We provide multi layers and level technical evidence that the Global Fund must continue to be a significant investor in middle-income countries with concentrated epidemic. But then they had come the political side, where, especially in this case, donors, but also some governments in the board, basically push for political decisions. Some of the decisions made at the board might not necessarily will be very technically sound or based on evidence. And by the same token, all the countries, eligible countries for these multiple windows of funding, so what we call the NFM4, which start next year, will be submitting proposals that will be reviewed by a technical review panel, which is totally independent from the board. But they will also find some inconsistencies of countries asking, not making a strong case to include, for example, hepatitis or co-infections interventions, hepatitis for basically the three avenues that OIL perfectly defined. So, and you know that one of the outcome of failing the target of the replenishment, of course, the 18 billion was more or less a dream, but this dream was an investment case, and this investment case have allocated money for catalytic funding, for special initiatives, the tools that the Global Fund as a partnership, but also the Global Fund Secretariat used to leverage and influence and catalyze some kind of work. Communities, gender and rights, key populations in the case of HIV, harm reduction is things that usually the Global Fund Partnership and the Global Fund Secretariat leverage with catalytic funding. This time we will have less catalytic funding, so it's important for you all, if you will be engaging in developing proposals for the next windows, is that the best way to counteract the lack of funding in the catalytic and special initiative is to make sure that the fight or the advocacy happens at the country level, and make sure that things that usually come from a different budget line in the Global Fund, it's expressed in the grant proposal. country coordinating mechanism, principal recipients, and technical partners at the country level would not afford to put working with key populations or hepatitis-related interventions in the unfunded quality demand format, because that will not be funded this time. Some allocations will be reduced, not in the key and priority countries, the 15 key and priority countries, but there will be some reductions in the allocation for funding. So our advice as a constituency of people living with HIV and affected by the other two diseases is, please start focus with your colleagues at the country level and build the demand for some catalytic interventions, including the one we are discussing today, to be part of the proposal, because we lacking money in other global fund features to catalyze and to complement. So that's very important to do this country ownership work, to make sure that the funding request, if the funding request that does not include some interventions, of course the TRP, which I believe is one of the key features of the Global Fund, will go back to the country and the country team in Geneva and say, why you don't focus on tripling elimination, why you don't, if you are testing people for HIV, do it for TB and hepatitis. All these kinds of comments for sure will come back from the TRP. But then, depending on how strong the TRP feel about it, the technical review panel, sorry, it will be ended or not in the proposal, or will be ended in a recommendation of developing a national guidance around triple elimination in the next 3 years, which is not what we need. So that's my outstanding message, and I'm coming to an end very soon. It's very important to understand that 2/3 of people with HIV lives in middle-income countries with concentrated epidemics. Middle-income countries and concentrated epidemics regrettably continue not to be a priority for the Global Fund, and that will be reflected in the allocation. And Eastern Europe and Central Asia, MENA, and other regions are affected by the co-infection of HIV and hepatitis, for example, due to the certain key populations like people who use drugs. So you need to build a case. And if it's country-driven, country ownership, you know that you need to manage the imbalance of power between government and civil society. Within the country coordinating mechanism, we still have country coordinating mechanisms really run and by the government. So it becomes very difficult to advocate for harm reduction or comprehensive approach to triple elimination or using testing for multiple diseases, and will continue to be the case because the governments will not change their approach to harm reduction and other key population, right? In a highly criminalized and context. And the last bullets I mentioned, if of course, as I said, we need to be very smart. There is a bit less money. We don't know with the current situation if all the pledge will be translated in contributions. Donors have pledged X amount of money. We have a better scenario after the last board meeting. So we're working into the new year with more money for allocations. Allocations letters are going out with a lot of annexes, including HIV and how the Global Fund wants to optimize and prioritize the HIV work in different contexts. Sometimes people complain about how prescriptive is the Global Fund, but without catalytic funding, with less money for almost not multi-country grants and not money for other strategic initiatives, we prefer to be prescriptive, because this being prescriptive is a tool for our communities to advocate to the government that we need to allocate money for key populations, to give you an example. At the country level, there will be competing resources. You will see CCMs with a lot of tensions because each constituency, including communities and NGOs and civil society, have different agendas. So we need to be prepared to compromise and reach consensus among ourselves. There will be support for civil society and CCMs, not only from the Secretariat, the platform for community right and gender, etc., but also donors had allocated a percentage of money of their contribution to provide technical assistance. How that will be implemented is a big question, but probably half of the donor constituency already in their pledging, they say this 3% of our contribution or 5% of our contribution will go towards providing technical assistance. So I think I will stop there because let's keep some time for debating. Thank you.
Thank you so much. So much in there. It's so great to hear, a view from your experience of being a board member and involved in the Global Fund for so long. I mean, there's so many things in there I think we're going to pick up in the discussion. Please do add your questions to the Q&A section, and we'll come back to them at the end. But I think there's so much there about the technical and the political, and the real need to build demand and the role of civil society in the whole thing, which is terrific. And I think the other thing that you mentioned is, even though this is the first time, it's kind of, or this information already expands the support. Countries have been using Global Fund support to do hepatitis elimination for quite a few years now. And one example of that we're going to have from Sopong. He's going to talk about their experience in Cambodia and using global funds to fight hepatitis. So Sopong, over to you.
Thank you, Gary. So I'll be talking about Cambodia Global Fund implementation experience here. Sorry, I can't move my slide. Okay. So in Cambodia, the government recognized that people who live with HIV or PLHIV, they are at higher risk for HCV infections. And in Cambodia, they are a very large populations. Based on a local study, they are 3 more times at risk for advanced liver disease, 10 more times at risk for liver-related mortality. Also, a study at one ALT site found that of all HIV patients screened for Hep C, 5.2% had already positive, and 3.5% had HCV infections. And Cambodia also recognized that PLHIV patients who are actively enrolled at ALT site, HIV program, they can be easily engaged and be provided with HCV screening, diagnostic, and treatments. With this strong rationale, in 2017, Cambodia, with support from partner, requested the repurpose of the HIV Global Fund underspend to support HCV screening, diagnosis, treatment among PLHIV across the country. So in 2017, the Global Fund approved the underspend. In January 2018, the HIV-HCV program began to launch. Service roll out at ALT sites. And I also want to highlight a little bit that following the successful launching of the HIV-HCV programming, later in 2018, there was a technical working group for hepatitis to think and to discuss about how to develop, a broader government-led hepatitis programming for among general populations, which in December 2019, the National Strategic Plan for viral hepatitis, HBV, and HCV, the clinical guidance for hepatitis management were developed and launched for the national program among general population. So here I want to emphasize that HCV, HIV programming is started, and then it provides momentum for this establishment of the national program. So back to the HIV-HCV co-infections. So by the end of 2019, the HIV-HCV co-infection program suspended because of the exhaustion of HCV commodities, and that it would require further funding to continue the program. And so by that time, there were around 41,000 of total adult PLHIV cohort that were screened for Hep C. And moving forward in 2020, the HIV/HCV programming was planned as a core strategy in the 2020 Global Fund request circle, which aimed to screen the remaining PLHIV who have not screened for HCV before. And the government also aligned to expand the service to include key population to access HCV screening at ALT side. So that includes PrEP candidates and also partner of PLHIV patients. So last year, COVID hit hard in Cambodia. So the program delayed, coupled with difficulty with procurement and supply chain. Actually, the start of the co-infection program, HIV/HCV co-infection program, has started in Q3 this year, actually, to screen and treat remaining PLHIV and key population, clients, and partner of PLHIVs. I also want to highlight it here that, with all the success story from the co-infection program for HCV, recently the government actually allocate the domestic budget of $1 million for the national programs to provide HPV and HCV service to general population starting in 2023. In addition to this, I also want to add that for the 2020 and 2022 period, Cambodia has leveraged the OSSA grant of the Global Fund funding to expand its effort to include HPV in its PMTCT strategies. Currently, the Cambodia MOH, Ministry of Health, with support from the OSSA grant, it's include, it have to include effort to support, triple elimination effort in Cambodia by providing HPV screening to pregnant women that come to have access to ANC during ANC within a health facility in the capital of Cambodia, Phnom Penh. So I just want to highlight that there are a lot of good success stories here in the country, here in Cambodia. So what are the lessons learned from Cambodia Global Fund implementation and advocacy? Just want to highlight that because HIV/HCV co-infection through the Global Fund support, HIV program is a vertical program. It has a regular patient engagement and follow-up for ARV, for HIV. So it's easy to provide. It's a very good entry point for HIV screening and treatment using this existing infrastructure where there is lab platform, blood transport, blood sample transportation in place, workforce in place already. Also, in terms of developing ME tool, it also easy because it can be incorporated into the existing HIV systems. Plus, the simplified algorithm for HCV treatment does not require especially to actually treat HCV patient, which is very easy with this already high cure rate of HCV treatment. And also want to highlight again that in Cambodia we have the Global Fund Offset grant to support the triple elimination effort, and in which this month, this year from July, the pilot screening of HPV to pregnant women started in the capital city. Also with the support again from the Global Fund money. With all the good things happening resulting from the co-infection HIV/HCV co-infection programs, it led to right now again the government providing $1 million allocation to provide to roll out hepatitis programming, HPV and HCV for general populations. In terms of some of the implementation and advocacy bottlenecks, of course, last year, including PMCT, HPV PMCT, and also HIV/HCV co-infection program, delay in commodity procurement, and also coupled with combined with COVID outbreak, made it impossible for the programs to relaunch or to start implementations. Which right now this year, all the program has been starting. Like in Cambodia, there is a department or national center under the Ministry of Health take charge of the national program for viral hepatitis among general population. And there is another program, separate program, vertical program for HIV, that they have this HIV HCV co-infection program. So there is this vertical program, so that there is somehow the disconnect between the two programs, which and also the PMCT and PMCT program. They are also another vertical program. So there is this connect between this program, which need to be a link, and that it would be easier to have a better implementation, providing hepatitis services to people. Currently, because of different programs, they have different responsibility and need. So so there need to be more engagement between the program, especially in the case of Cambodia. Supply chain difficulty, again, already talk about that. Like PMCT program last year, they could not start the screening of pregnant women in the capital city because they simply could not find supplier for HBe antigens. In Cambodia, they do the PMCT guideline. They don't use HBV DNA viral. They use E antigen and also ALT testing to diagnose pregnant women who would be eligible for the prophylaxis of TDF during their AMC. And also there is some limited awareness of the global funds policy, like the information note that recently published for those who work in the hepatitis space here in Cambodia, and that the success, like Orias mentioned earlier, would depend on engagement from different stakeholders and actors in the country, and that need to be more voice in terms of new guidance on how the global fund encourage country to include hepatitis into the upcoming applications. And I put last year about the Cambodia success of, even though it is a very small money, but the government has allocated $1 million, which is a great thing. And I'll end it here and back to Gary. Thank you.
Sorry, my camera is taking a long time to turn back on again. Thank you so much. And thank you for all the amazing work that you are doing in Cambodia. And I think it's such an excellent example of how, global fund support can be a catalyst for domestic funding and for hepatitis. And it's just fantastic to see, that really coming to life in Cambodia. But of course, as Javier spoke about as well, we need to make the case for the inclusion of viral hepatitis within Global Fund programs. So I'm really happy to introduce Sam from Harm Reduction International to talk about some of the resources they have around harm reduction and hepatitis. So Sam, please.
Great, thanks very much. So yeah, good afternoon, morning, evening, everyone, wherever you are. Thank you a lot for the invitation to present our work here. At Harm Reduction International, we're really happy to be kind of increasing our engagement with the hepatitis community. So today, I guess I'm here to put forward the perspective from harm reduction, which I'll do through the lens of some of our research, particularly the Global State of Harm Reduction report. This is one of our flagship reports. It's released every 2 years, tracking the implementation of harm reduction programs around the world. So there's a lot of data contained in 9 regional chapters plus 2 thematic chapters on COVID and hepatitis, but I'll try to summarize the kind of key overall findings over the next few minutes, focusing on those services most relevant to hepatitis. So the most significant overall finding is that harm reduction is more widely implemented in 2022 than 2020. And that means it's more widely implemented than ever before. Today, there are 92 countries in which you can find at least one needle and syringe program. That's 6 more than we found in 2020. And there are now 87 countries where there's at least one opioid agonist therapy program. So that's 3 more than in 2020. And it's worth highlighting that all of the new countries implementing NSPs and OAT are low and middle income countries in Africa. Next up, since 2020, 4 more countries have opened drug consumption rooms, or in the case of Mexico, moved to kind of formalize a pre-existing service. Drug consumption rooms can be a little hard to count. because there are some issues related to identifying like what is an official or a recognized facility. But we now count 16 countries worldwide in which there's at least one drug consumption room with some kind of state approval. So those are the interventions most relevant to viral hepatitis that we've been monitoring since 2008. Nevertheless, as I'm sure many of you know, these reflect a model of harm reduction that's really focused on injecting drug use and opioid use, and to respond to the needs, including the hepatitis prevention needs of all vulnerable people who use drugs. There's a need for a greater range of services and perspectives. So in that context, we've widened our research to collect data on interventions for people who use stimulants and people who smoke their drugs. This is an area where the Global Fund have been expanding their information notes on harm reduction to make it more feasible to fund programs for this population. So we've found 2 countries where there's a stimulant pharmacotherapy program. So that's a program roughly corresponding with opioid agonist therapy, programs where people who use illicit stimulants can be prescribed a regulated stimulant to support them to manage their use and reduce harms. And then there are 20 countries in which safer smoking kits are distributed to people who smoke drugs. And those kits can include pipes, among other things. And there is, as I'm sure many of you are aware, some evidence of viral hepatitis transmission through pipe smoking, though that's an area where there's definitely more research needed. But in any case, these are programs that can prevent other communicable and non-communicable diseases. So having said all this, it's worth emphasizing that this is only the first step on a road towards harm reduction that works for everyone. We need more research, more dialogue with people who use drugs to understand what services are needed to reduce the harms of different classes of drugs, including those harms related to viral hepatitis. So overall, to kind of wrap up this section, it's good news that harm reduction is spreading, particularly in low and middle income countries, but there are still significant problems with availability, accessibility, and quality. So, you know, we're not there yet. There's a kind of a further finding from the Global State report that lies slightly behind the numbers. Between 2020 and 2022, as I'm sure you're aware, the world has been through several crises: the pandemic, the invasion of Ukraine, political, economic, meteorological, environmental crises. And all of these impact the most vulnerable the hardest, and among them are people who use drugs. So in our research, the experiences in each case of crisis have really underlined the importance of civil society and organizations built and led by people who use drugs themselves. In all the crises we looked at, from Ukraine to Lebanon to Afghanistan, we saw that it was these kinds of organizations that were the most flexible, the most adaptable, and the most dedicated, and who knew best the constantly shifting needs of people who use drugs. So it's completely essential that we continue to support, fund, strengthen civil society and organizations and networks of people who use drugs. So that's the global state of harm reduction. Like I say, it's a fast overview. There's a lot more data in the report, including on naloxone, more information on financing, on harm reduction for underserved communities like women, Black, Brown, and Indigenous people, LGBT plus people. So please feel free to get in touch with any questions. I also wanted to share another project we've been working on that's of interest to this group in particular. So we've worked with partners to bring together data on viral hepatitis and people who use drugs from various publicly available sources. We call it the Viral Hepatitis Data Repository, and it's available on our website. That's hri.global. I thought I'd just do a very fast kind of walkthrough to introduce it. It can be found under the Drugs and Health banner on our website, Drugs and Viral Hepatitis. If you follow that through, you'll find these 12 indicators that we provide data on, which hopefully would be of interest to people preparing funding requests to the Global Fund. So please, if this kind of thing is your thing, do explore the data, get in touch with any questions or recommendations on how we can make it more useful to people like you looking for this kind of data. Yeah, so that's it from me. Thank you very much. I'll put a couple of links maybe in the chat, as well as my email address for any further questions. Thank you.
Thanks, Sam. Really, really valuable resources there. So thank you for sharing that work. So now we have time for some questions and answers. Thank you for everyone who's already put a question in the box. If you would like to ask your question live, please do raise your hand, and we will turn on your microphone, and yeah, you can ask your question. So I'm just going to dive in. I think Orioles had to leave us, but the rest of our panelists are here for your questions, so please feel free. So Javier, I think this one is probably one for you that's in the question box from Michael Napai that says, is it possible to know what were the reasons behind the Global Fund not widening the scope to access viral hepatitis services in the past? Is it only financial? Assumptions or perceptions of recipient countries were not ready? Was it perhaps to somewhat lack of evidence on key populations, PWIDs or pregnancy? Thanks for the clarification on the reasons so CSOs can react better to structural barriers. Thank you.
Yeah, to tell a 20 years old history in a nutshell, I think the problem with the gift of the Global Fund is that some needs for particular populations evolve over time. So I think that board constituencies, technical partners, when I say technical partners, I'm not only thinking about WHO, I think about Back Malaria, Stop TB, etc., and CHAI and others have been pushing slowly to introduce, for example, offering same testing, of having a testing kit that covers more than one diseases. In our case, for example, recently we pushed that portfolio optimization could be used in some concentrated epidemic for monkeypox, not without vaccines, things like that. We try to find the gap on few things and build a case. Of course, then this case needs to be supported by the TRP with a technical sound and evidence-based good proposal. But I think that probably in the past, the board were more mission-oriented, more focused on the three silos of HIV, TB, and malaria. And we all learned together in 20 years that to deliver on some, for example, HIV outcomes, we need to work on hepatitis. I mean, and there is a increasing understanding and consensus across the board. That's one thing. The second thing is that wherever our civil society in countries at the regional or global level, sometimes and implementers governments, sometimes they see evolutions on increasing the investment on particularly things like hepatitis as a threat to the business as usual allocation money for the usual work without thinking on the importance of evolve and be more innovative, etc. We have now discussion, as many of you know, about next generation innovation. As mentioned by Chai, we have a procurement mechanism that wants to also offer in good quality medication for non-global fund grantees. There are some innovation ideas that sometimes create some concerns on donors or some concerns on implementers that we might deviate it from the core mission. And I recall a policy paper from Chai about myth on, well, if you're funding hepatitis interventions, I don't know, hepatitis B vaccine for people living with HIV, then you are deviating from HIV, TB, and malaria as the only three silos or vertical approaches, which we know is not true. But again, some constituency in the board, whatever are donors or implementers, sometimes they may or we may some decisions based more on policies and politics rather than in evidence. So we need to put that into the equation when we want to continue pushing the hepatitis agenda in the Global Fund.
Thank you. That's a great answer. So I think I see a hand up from Dr. Samia. Dr. Samia, would you like to ask a question? Feel free to unmute your microphone, Dr. Samia. Okay, maybe just while Dr. Samia is sorting out his microphone, maybe we can just go to Kenneth. Kenneth, please, the floor is yours.
Thank you so much, James, and our panelists. My question goes to Javier. I really want to understand whether Global Fund will have some bit of support towards the civil society organization, because you will bear with me that looking at the HIV community, much of the work, especially to do with the community mobilization, has been done by the civil society organization. And we credit Global Fund for the support that they have availed to the HIV community. So we really want to understand, is there going to be an opportunity for the viral hepatitis civil society organizations also have an opportunity to submit in their grant applications? And if that opportunity is going to be there, when do you expect this to happen? And maybe you could share some of the resources so that civil society organizations in the viral hepatitis space can begin to think on what kind of projects they can submit towards. Thank you.
Yeah, sure. I think that the answer is yes. I think towards the years and during each and every time that a country, CCM, the in-country partnership develop a funding request, depending on the dynamic of the country, you have the opportunity to ask for many things. I want to draw the attention to the new Global Fund strategy. The TRP, as well as all of us, we will be looking on our primary goal, which is working with and to serve health needs of people and communities. And if you see, I invite you, you can Google will be appear in your screen, the new Global Fund strategy and the overarching framework. You will also see that the mutually reinforcing contributors are maximizing people-centered integrated system, maximizing the engagement of leadership of most affected communities, maximizing health equity, gender equality, and human rights. That are the three pillars that sustain the ends AIDS, TB, and malaria overarching goal. How we translate that into action is the 1 million or 1 billion or 1 trillion question, because there are dynamics in each country within the CCMs and within the broader partnership that support the implementation of a Global Fund grants and the concept node development of funding request development. And this time, I mean, the next year will be critical that the main, sorry to use the expression, the main fighters or the main advocates to include things around hepatitis and other things that requires and push people at the center and communities at the center will happen at the country level. And it's not only because we have less money for catalytic funding. When a funding requests reach the TRP with significant and meaningful engagement of communities and community health workers and community advocates, and measure to support the response of civil society and the people living and affected by the diseases, TRP loves that. The TRP is also made not only by technical experts on HIV, TB, and malaria or RSSH, they are made of civil society and community activists. But to end my reflection, we also need to acknowledge that there are tensions in many CCMs, and now it's time to probably put some of the tensions and difference or infighting aside and be very tactical as civil society and community to make sure that the funding requests that will be sent to the TRP review have all what we need in the main proposal. I know it's not easy, but that will be my strong advice, to make sure that you have enough resources for the next 3 years.
Sorry, apologies for the delay. That's a really comprehensive answer, and I think it does address two of the other questions in the Q&A box. I mean, one of them is asking about, the likelihood of bigger agencies might be overshadowed by smaller ones. And so is there going to be any special funding applications, support, or special funding systems for new or relatively small CSOs for the upcoming opportunity? I mean, I think a lot of that will come down to a national level, I would imagine. Would you agree with that, Javier?
Yes, absolutely. And bear in mind one thing. We ran out of money to multi-country grants. And multi-country grants were instrumental for getting regional networks, civil society organizations to push for example, making money available for key populations or harm reductions initiative out of the country into countries who may not be eligible or may be highly discriminating and criminalizing those key populations. That's more or less, if you see the final number, it's only 30 million. It's almost gone and will be used probably on whatever TB, malaria, cross-border response. So I think we need to focus on expressing the demand and give the fight at the country level, most definitely, with the current funding situation. And please ask before or after Christmas, people in this call are linked with the CCMs or they are sub-recipients, implementers. Please call your principal recipient, call people in the CCM to see the allocation letter. Not only to see the amount per the 3 diseases, but also to read the probably 8 or 9 pages of annexes with links to different new and old policies of the Global Fund. You all have the right to see the allocation letters, which have some tailor-made recommendations, very few, but mostly speak about, for example, the gender policy, the key populations recommendations, etc. That will be your key tool for in-country advocacy.
Great, thank you. And I just wonder, Supong, if you had any reflections on the civil society involvement in Cambodia and how that sort of came about and how communities got involved. Oh, I think you're on mute.
Sorry. Yeah, I do agree. It depends on country and also in country CCMs.
Hello. You can.
Sorry, please carry on.
Actually, it's very difficult, because like in the case of Cambodia, a lot of local organizations they are working with on HIV, so not many organizations but on hepatitis. So during the CCM oversight committee, so what we have been working on actually right now, for example, I went to a meeting with local organizations, work on HIV outbreak activity to bring out about hepatitis, especially the consideration to expand HCV screening and treatment to PLHIV population who is pretty vulnerable to the infections. But it's a very hard fight. It's because organizations like in Cambodia, they have different priority and need. So I think it will take time. So right now, like CHI in Cambodia, we try to identify different members of the CCM, like local organization, and try to discover them to bring out hepatitis and the infection that can really aggravate all these key population and HIV patients. Thank you.
Excellent, thank you. So we've got lots of hands raised, so I'm going to go back. Dr. Samia, I think your microphone is working now. Would you like to ask your question?
Yeah, thank you for organizing committee. You arranged a very wonderful program. I'm from Pakistan. Is Pakistan have a lot of issues for hepatitis in working. Lot of patients are unidentified due to unknown reason for liver cirrhosis and liver transplant. So how can connect for your international organization to collaborative research to facilitate the common people to free diagnostics testing? How can join the mega research group working? Any study group in Pakistan, those are working for hepatitis, you know, any person, how can connect? I'm working in public health. I'm the microbiologist and working lot of public issues. The patient comes to doctor when the livers are totally failed and liver cirrhosis in occur.
Thank you, Dr. Samia. Javier, perhaps you don't know the details of the situation in Pakistan, but if Dr. Samia wanted to engage, what would you suggest is the best route?
Well, the best way is that luckily the alternate board, my alternate board member, it's a young leader from Pakistan. So that's a shortcut. I will put my email in a minute in the chat, so we can connect people. I think that it's important. Countries like Pakistan and other countries with not only issues around harm reductions or people with HIV are those countries where are very important we start, if it's not started already, like Cambodia and others, to leverage access to resources for hepatitis and diagnostics and testings of multiple diseases is something that will easily pass the TRP screening, because as far as probably all the people in this call and probably a significant part of the Global Fund board, we don't believe in that strict definition, but whatever, including RSSH, whatever the Global Fund does, needs to have a result on HIV, TB, and malaria. Whatever we will be doing on pandemic preparedness, and whatever that will look like next year, needs to have an outcome on HIV, TB, and malaria. But that's also an entry point. I think as a person living with HIV, I believe that many people, many colleagues and friends have access to diagnostic and even treatment and cure of hepatitis, thanks of how the nuance, the granular you can be in a grand proposal. And the last point on Pakistan, we will be seeing countries facing whatever is related to climate or different new pandemics or endemics or issues enter into a situation of emergency. I believe, not because I'm part of the Global Fund partnership, but I do believe that the Global Fund has been responsive on crisis, and it's happening with Pakistan, and now happening with Pakistan, with Venezuela, with COVID across the road during the first emergency approach. So it's also important for us to keep some emergency resources to respond to a climate-related or a disease-related outbreak that jeopardize work on HIV, TB, malaria, and that's also part of our SSH. But I put my email, doctor, so I can introduce you to Ali, who is the alternate board member who happens to be and work in Pakistan.
Excellent, thank you. And on that same theme of making connections, there's a question in the Q&A that says, how can in-country health advocates who have not been involved in this before identify local groups working on the Global Fund process to contribute towards pushing for the inclusion of viral hepatitis and harm reduction programs in their national submission? So I guess, yeah, I mean, obviously there's opportunities maybe around the GFAN network, but also through the Global Fund. What do you think, Javier? Oh, you're on, sorry, you're on mute, Javier. Sorry.
Yeah, I'm talking to myself. I think it's important. I mean, after 20 years of my relationship with the Global Fund is longer than my marriage. So after this long relationship with the Global Fund, one of the main challenges how civil society and communities get together at the country level and take advantage of this space called country coordinating mechanism, also to make sure that there's enough money allocated for them as a sub-recipients, but also push the needs and agenda. So in the future, we will have less money and we will have much more deliverables or needs to fund in our countries. So I always appeal to communities and civil society in each country. We prioritize, the communities delegation prioritize as one theme for the next 3 years to continue supporting, strengthening the country coordinating mechanism. To don't end it in the situation where many countries having an absolutely dysfunctional CCM, where even civil society and communities fight. And the final point is that when someone is selected to be member of the CCM, it's not because he's cute, he's smart, or something like that. He's representing their one or multiple constituency. Imagine in a country with a concentrated epidemic, you will not have a representative from each and every key population. Or maybe yes, doesn't matter. But I mean, governments are not very fun for this approach. So if a female transgender are representing key populations or sex worker communities, needs to consult with her. They need to think, as we also think in the board, they need to engage with their constituencies or multiple constituencies. And the same for people working on TV. I mean, people, as people living with HIV, people working on HIV, should be, and people working on harm reduction should be the champions on this discussion around hepatitis at the country level, and get support from the TB and the malaria community, because they also have other agendas that the Global Fund has failed to properly fund it in the past. So we need to open the cluster or the silos and create some new dialogue with other activists and advocates responding to other diseases. We know that malaria is highly medicalized. We know now hepatitis is no longer highly medicalized. That's good news. So we need to take advantage of that and at least put on hold whatever different agendas and infightings or backpacks for the funding request writing season, because it's your opportunity to get the money you need for your organization and for your priority.
Excellent. And just about the Global Fund Advocates Network, do you think that's a way for traditional hepatitis organizations to engage in the world of Global Fund?
I think that for now, the core business of the Global Fund Advocate Network has been focusing on supporting the replenishment. And even we're still trying to recover from the last replenishment. The next replenishment will start in 2 years. So, I mean, honestly. And we are also trying to discuss, because each and every future replenishment might probably be harder, we are discussing with the Global Fund and G Fund what kind of work we continue making in between replenishment conference and cycle. And for me, working and living in Latin America, I could tell you that we need to do better domestic resource mobilization. We need to create more pressure into our governments to funding, as my country, who is not eligible for the Global Fund, the response to hepatitis and curing hepatitis C was fully funded by the government. But then we faced the issue of demand. We couldn't find people that required to be treated and cured of hepatitis C. So, and hepatitis B, it's included in the package of services for key populations in my country. So the future of this partnership relates on our ability to get the political commitment of our government to increase the domestic resources instead of buying weapons. Because and I think GFAN, it's also engaging in ACTAID, it's engaging in discussion around global financing. I think this is probably the core business. Specific diseases or comprehensive approaches to disease and key populations, the perfect season to partner with GFAN and the Global Fund constituencies, your constituencies, is when we start looking into the next investment case. In the meantime, discussing domestic resource mobilization, discussing global financing is very important for the Hepatitis Alliance and their members to be fully engaged. But I mean, GFAN have a sort of set of core business, which we basically really appreciate.
Excellent, thank you. Well, I'm afraid we're at the end of our time. I know that several people still have their hands up. If you would like to email your questions to us, to the contact address on the email you received about the webinar, we'll do our best to answer them. Or if you can get them into the chat or the Q&A now, we'll do our best to answer them. But it just leaves me enough time to say thank you to all of our panelists. Thank you to all of you who attended. It's been a really fantastic session. I think I've learned so much. I hope all of you have as well. And we look forward to taking this, conversation on and really taking some actions from this to, increase the support for hepatitis elimination within Global Fund programs. So thank you all very much, and I'll see you next time.
Thank you, bye.